It's a kind of strange title for medical grand rounds, but I hope to show you the relevance of what I'm going to talk about, not just for the disease that I treat and do research with, diabetes insipidus, but the potential ramifications for other diseases that either have been or should be renamed as well. And I've been talking about this nationally, so I thought, why should I talk about this at other places and not at our own institution? So I decided it would be a good topic to cover today. So this one slide, again, still doesn't advance. These are my disclosures, which none of which are relevant to today's talk. And this one slide summarizes what I'll tell you today. We have proposed this name change. Central diabetes insipidus will become arginine vasopressin deficiency, abbreviated AVP-D. And nephrogenic diabetes insipidus will become arginine vasopressin resistance, abbreviated AVP-R. We've published this proposal as an editorial simultaneously in about 8 international journals. And it has now been endorsed by all of the major endocrine societies worldwide. That's 5 continents, not Antarctica. We couldn't find an endocrinologist there. And we should have gotten someone from Africa, but we didn't. And that's one of the publications. But again, it's simultaneously published. So it's available worldwide in terms of understanding both the proposal and, what's importantly, and what I'll talk about today, the rationale for the proposal, because you shouldn't just willy-nilly propose a name change without a good reason for it. Now, in terms of names, remember that this is not news. I mean, Shakespeare 500 years ago reminded us that names are just surrogates for people or objects. It's really the people or objects that are the same. In this case, diseases are the same, regardless of what the name we use for them. As I said, this goes back quite a ways. So I've listed 5 rationales for changing a disease name. And we're going to go over each of them, but I'm going to concentrate on number 5. The most important one is we have a new understanding of pathophysiology, genetics, proteomics. It gives us an understanding of the pathophysiology that we didn't have when the disease was first named. So now we can name it more appropriately according to the pathophysiology of the disease. Secondly, we're very much cognizant that most science today is team science. It's not one individual who makes one discovery, but a team. So in the past, diseases tend to be named after an individual without recognition that there were probably others that were involved in discovering that disease. Third is something that has been recently done by my rheumatology colleagues, is appreciation that some people who have diseases named after them actually engaged in medically unethical behaviors, and therefore it wasn't appropriate to continue them as being named for that disease. Fourth is that eponyms often lack scientific accuracy. I mean, we know what Cushing's disease is, named after Harvey Cushing, but just because it's Cushing disease, that doesn't tell you anything about the scientific basis for the disease. And finally, traditional disease names might lead to confusion between pathophysiologically different processes, and that can lead to treatment errors and consequent adverse outcomes from patients, which is what I'll go into in more detail today. But before we go any further, we need to have some definitions. And this is a definition that we don't often either recognize or use, but you need to understand some of these rationales for changing disease names. An eponym is a word derived from the name of a person, and importantly, it can be real or fictional. And a medical eponym is thus any word related to medicine whose name is derived from a person. So again, Cushing's disease, named after Harvey Cushing. Medicine loves eponyms. There are thousands of eponyms. And if you don't believe me, go to this website, Who Named It? will list every medical eponym that either has been or is used. This is one page from that website, just the eponyms beginning with B. There are 35 pages listed here for this particular, for B. It is the winner. If your last name begins with a B, you're in good company because most medical eponyms begin with B, 875, and that's just the letter B. S is a close second, and then all the rest. But the point is, eponyms are pervasive throughout medicine. We use them every day, and they're part of our general language and our general care of our patients. And that's where some of the problems lie. So the first rationale for changing the name, we have a new understanding of pathophysiology. So here are 3 syndromes named after people. Chiari-Fromell, postpartum galactorrhea, amenorrhea in females who decided not to breastfeed. Forbes-Albright, galactorrhea, amenorrhea associated with a pituitary tumor. And Ahumada del Castillo, galactorrhea and amenorrhea not associated with pregnancy. You know, my endocrine fellows wouldn't even know what these 3 syndromes are because we don't use them anymore. There's still ICD-10 codes for some of them, but they're totally not used. Why? Because we know the common pathophysiology for amenorrhea and galactorrhea is elevated prolactin levels. So now the terminology of hyperprolactinemia has appropriately superseded these individual syndrome names, which are named eponymously, i.e. after the individuals who either discovered or first described them in print. Secondly, a previous eponymous name for a syndrome was attributed to an individual who is not the first or even the most significant person involved in the description of the syndrome. There are many, many examples of this, but I'll just give you one. Behçet's disease, first published by Halouchi Behçet, 1937, but actually a case was described in 1930 by an earlier investigators. And the people who write about Behçet's disease and know the history of it point out that about 28 different individuals have been associated with discoveries related to Behçet's disease. So if you really wanted to be appropriate and fair to everyone, it would be renamed by what's in orange there, beginning with Hippocrates and ending with Behçet, with another 26 people in between. Clearly ridiculous that we would name diseases that way, but it just points out that the attribution of a disease to a specific single individual is not really historically appropriate in many, many cases. Thirdly, the appreciation of medically unethical behaviors of individuals with diseases named after them. Most famous of this is Wegener's granulomatosis, which was renamed granulomatosis with polyangiitis in 2006 because of the later recognized participation of Wegener in the Nazi Party both before and during World War II, and his presumed participation in war crimes, though that was never officially documented anywhere that I know of. And importantly, we took recommendations from our rheumatology colleagues who did this renaming in terms of how we should go about renaming diabetes insipidus. And importantly, they garnered the support of patient groups advocating for the name change. The Vasculitis Foundation North America published a letter in Lancet stating, I think very clearly, as patients and family members, we would prefer a different name for our disease. Patients' opinions about what their disease is named is important, as I think you'll see. And a similar rationale was used for changing the name of Reiter syndrome to reactive arthritis, again, participation in unethical behavior during World War II as part of the Nazi war crimes. Fourth, eponyms obviously lack scientific accuracy. I've already told you that in the example of Cushing's syndrome. But also, if you look at eponyms for the same disease, you can find multiple different names given to those disease. Ankylosing spondylitis, just one example. Those 7 different terms have been used at times to refer to that disease. Obviously, that's confusing. I mean, we confuse medical students enough, let alone have them confused by what a disease is actually called. And again, this is promoted by Dr. Madison from the Mayo Clinic, who spearheaded the effort to change the name of Wegener's granulomatosis. And I give him credit for the advice that he has given us for the DI name change. So none of these first four apply to our proposal to change the name of diabetes insipidus. Rather, it's number 5. That's the reason why we are proposing, and in fact have done this. Traditional names can lead to confusion between different processes pathophysiologically, leading to treatment errors and consequent adverse outcomes for patients. Do we have evidence for this? Because, you know, it's 2023, we don't do anything without evidence, or at least purported evidence. So yes, we do. Here's a case of diabetes insipidus that should have never happened. And it happened in the UK, and it's in print. You can find it at the reference at the bottom. 22-year-old man, London Teaching Hospital for elective hip replacement. He was known with the diagnosis of panhypopituitarism and diabetes insipidus. But when he was admitted to the orthopedic service of this London Teaching Hospital, his desmopressin or DDAVP was discontinued since they knew this wasn't a treatment for diabetes. Use insulin and other diabetic drugs for diabetes. So they discontinued the desmopressin. Hip operation went without incidents, confused postoperatively. His mother told the staff he gets like this when he doesn't take his medication, but they still didn't give it to him. The following day, more confused, they got a psychiatric opinion, which didn't help for obvious reasons. It just meant it wasn't just the orthopods who didn't know what diabetes insipidus was. They sedated him, they put him in isolation. He called the police on his phone and said, "I'm so thirsty and they're not giving me anything to drink." This is all documented in the reference below. The police came to the ward. They didn't know about diabetes insipidus either, obviously, but they were assured by the ward staff that he was being taken care of appropriately. Laboratory testing showed, surprisingly, a normal serum glucose. Always had been normal. They checked many, but the serum sodium was 149. 9 o'clock the next morning, had a fatal cardiac arrest. The serum sodium was 169. This is a case of a death that didn't need to happen because of a failure to recognize that diabetes insipidus is not diabetes mellitus and requires a different therapy. Now, I've never seen a case like this at Georgetown. I'm pretty sure it wouldn't occur at Georgetown. I've never seen one or heard of one reported in the United States. So some might say, well, this is a pretty bad case, but it's a single case. You're not going to change a name just because of a single bad case like this. How rare is this occurrence? So the UK National Health Service decided they would try to find out, and they surveyed or studied 471 adverse events that were registered involving the drug desmopressin, usually known as DDAVP. Most of the adverse events involved either an incorrect dose, 12%, or more telling, complete dose emissions, 16%. And of those dose emissions, there were 4 cases of death caused by severe dehydration. So it's not an isolated single case. It might be rare, but it has killed people. So I mentioned before when talking about my rheumatology colleagues that they asked the advice of their patient representative group in turn before they really went ahead and proposed a name change. And so we did the same thing. Patient responses, patient opinions are important for many things, but also for whether we should rename the disease that they have and which they are carrying. So we did this international survey, mostly US, UK, and Europe, and published it in 2022. We had responses. This was done as a web-based survey online. So, patients were informed of it and they could go to the URL and register their opinion. We had over 1,000 patients with a diagnosis of central, not nephrogenic, but central diabetes insipidus. I just show all the various etiologies, everything from idiopathic to structural lesions to genetic causes to post-traumatic causes. So, the typical wide spectrum of disorders that cause diabetes insipidus, but importantly, over 1,000 patient responses. And I summarize here, there's a lot more in this paper than just their opinion about a name change, but I summarize here their opinions with regard to the name of diabetes insipidus. 80%, almost 4 out of every 5 patients said that healthcare professionals had confused their disease with diabetes mellitus on at least one occasion. Now, 4 or 5 deaths is rare, but confusing diabetes insipidus with diabetes mellitus, that's not rare. 84% thought that physicians in general had an insufficient understanding of central diabetes insipidus and rated this only 2 out of 10 in terms of knowledge on a visual scale. 87% thought that this poor knowledge of diabetes insipidus affected management of their condition, and a lot of them specified in their comments they kept on having repeated blood glucose measurements in the hospital because of nursing staff thinking that they really had diabetes mellitus. And finally, 85% preferred that the name of the disease be changed, and specifically, they said, we don't care how you change it, but it shouldn't have diabetes in the name because that's what's causing the confusion with diabetes mellitus. So that's what our patients think, and that guided us along with the terrible cases that I just showed you. So importantly, in understanding whether a name should be changed, you need to understand the history. You need to understand how we got to where we are today if you're going to propose that we ought to change the name to something that has been around for really centuries in terms of diabetes. So this description, I don't know why the top is cut off by the banner at the top, but this is the first really published description of diabetes by Aretas, the Cappadocian, in about 100 to 200 AD. Diabetes is a wonderful affliction, not very frequent among men, meaning among people really, being a melting down of the flesh and limbs into urine. The patients never stop making water. The flow is incessant as if from the opening of aqueducts, which is where the term diabetes comes from. Opening of aqueducts or siphons, therefore allowing a rush of water forward. Goes on below, moreover, life is disgusting and painful, thirst unquenchable, excessive drinking, which however is disproportionate to the large quantity of urine, for more urine is passed, and one cannot stop them either from drinking or making water. You know, this is a very flowery description of diabetes. It's not the terminology we usually use in the scientific literature today, but it is very graphic and a very appropriate description of the disease. Cappadocia, right now it's part of central Turkey, but at the time of Aretas, the Greeks controlled that whole area, so he's Aretas, the Greek, not the Turk. And if you look at the actual history of diabetes, it was described even before Aretas wrote his clinical description, going back to 552 BC and the Egyptians, other Greek authors. In fact, the first word of diabetes wasn't, the first use of diabetes wasn't by Aretas. It was by Demetrios of Apamea, who none of us recognize as being involved in the discovery of diabetes. So, you know, Aretas is given credit for discovery, even though there was knowledge that this disease occurred way before his time. Why was he given the credit? Because he published. So this is the text from his treatise on diabetes, diabetes. And this is a lesson for the residents, fellows, and students in the audience. You might discover something first, but if you don't publish it, you're not going to get credit for that. So we give Aretas credit just because this was the first publication describing the disease of diabetes. And so diabetes means passing water like a siphon or aqueduct. That's from Greek because Aretas was Greek. Many people, including my colleagues in diabetes mellitus, think that the Greeks also discovered that diabetes was diabetes mellitus, or urine like sugar or honey. But if you just look at the terms, you'll know that can't be the case. while diabetes is a Greek derivation, mellitus is not. That slide did a funny thing. But mellitus and insipidus are of Latin derivations. The Greeks did not give Latin names to anything that they did because they came before the Romans, and so they couldn't have given Latin names. It had to be later. How much later before mellitus got associated with diabetes? Well, about 1,500 years. And the person who did that was this man, this physician, Thomas Willis. You remember him from anatomy because he described a circle of Willis at the base of the brain, but he also took care of a lot of different diseases and patients. And he was the first to do the famous taste test to determine whether the urine was sweet or not. You know, I often joke that you would expect that the first person to do that kind of test would have been a Brit rather than a Greek, and it was. And he, again, just like Aratus, gets credit for this discovery, or should, because he was first to publish. And this was from his treatise, hard to read because of the fact that the S's all look like F's at that time. But his treatise was called The Diabetes or Pissing Evil, which is a great, again, description of the fact that this diabetes uncharacteristically was associated with not just increased urine production, but increased sweet urine production. And that's what mellitus means, sweet like honey in the Latin derivation. Now, diabetes insipidus, that came much later than the discovery of diabetes mellitus. It's attributed to a Italian investigator, Johann Frank, who described patients in 1794 characterized by long, continued abnormally increased secretion of non-saccharine urine, meaning non-sweet. And he was the first to use the term insipidus, which is from the French insipide. Now, I don't know, which means tasteless. I don't know why an Italian investigator chose to name this after a French term. You know, I don't think we'll ever understand that, but it was, and that's where we get insipidus. Subsequent discoveries describe the hereditary nature of DI, mostly in males, showing that there was recognition that there was a genetic cause of nephrogenic diabetes insipidus. But most of the cases still were central, and that was proven by the first successful use for treatment of central DI using posterior pituitary extracts. In fact, in 1921, it wasn't called diabetes insipidus. It was called hypopituitary syndrome because of the recognition that these central cases were due to deficiency of production of something from the posterior pituitary that caused urine concentration or antidiuresis. But then again, investigators soon described some cases of DI in male children who didn't respond to posterior pituitary extract, thereby establishing that there were two types of diabetes insipidus, both central and one related to the kidney. I can't not show this because this is really the very first hormonal therapy that was ever applied to treat an endocrine disease. People had used testosterone extracts, brown Sicard before this. Wasn't to treat a disease, it was just to try to make them stronger and live longer. But to treat an actual disease, the first treatment was posterior pituitary extract, which of course they didn't know, but we know now, contains arginine vasopressin. So if you look at this patient, excreting between Roman numeral 6 and 7 liters a day of urine, given posterior pituitary extract here, you see the urine volume fall, urine concentration increase, and then a return of the polyuria after the single dose wore off. So this disease, diabetes insipidus, has a long history. We know that history, and it has a long history of actual treatment with the appropriate hormone, which is now we know arginine vasopressin. So to just move us into the present day, these are the disorders of inappropriately decreased AVP or AVP effects. So decreased AVP, AVP deficiency, decreased AVP effect, AVP resistance. So AVP deficiency is what we had called and do call central diabetes insipidus. Most commonly it's traumatic, less commonly genetic and acquired. ABP resistance or nephrogenic diabetes insipidus is either genetic or acquired, most commonly probably genetic. And then we also have to distinguish these two forms from primary polydipsia, which is technically not a form of diabetes insipidus, though I will show you at the end it actually is. We just haven't recognized it previously. Gestational AVP, mostly deficiency, very rare, and osmoreceptor dysfunction, which is a different form of diabetes insipidus. In terms of traumatic etiologies of ABP deficiency, mostly these are due to surgery or trauma that involves the base of the brain because that's where the posterior pituitary is. And we see this after surgery for pituitary tumors, meningiomas, anything, craniopharyngiomas, anything that's in that area around the sella turcica, where both the anterior and the posterior pituitary are located. So it's very common after that kind of surgery to see a transient diabetes insipidus, increased urine volume, shown here, but only for a short period of time, generally resolves by the time the patient is discharged. Permanent DI, much less common, only 1 to 3% of pituitary adenoma surgery, but 10 to 25% of craniopharyngioma surgery because those are bigger tumors. They're more superior located, more likely there's going to be damage, not just to the posterior pituitary, but also to the hypothalamus, where the ABP is actually synthesized. And then a very rare form of triphasic response with DI followed by SIDH, and then recurrence of DI, which we're not going to talk about today. In terms of non-traumatic etiologies, they run the spectrum from genetic to tumors in the brain, to Langerhans cell granular histiocytosis, or in adult sarcoidosis, because this is a pediatric study. But I'll draw your attention to the fact that 54% of these cases are idiopathic. And there we've made recent advances in understanding what causes idiopathic diabetes insipidus. And it is due to an autoimmune process in which there is infiltration of the posterior pituitary by lymphocytes, shown in this biopsy of a thickened pituitary stalk in a patient with DI, stained for this particular lymphocyte antigen. And we now know that most of these cases of idiopathic are from an autoimmune disease that attacks the posterior pituitary, and we call it lymphocytic infundibular neurohypophysitis. Now, that's a pretty long word to remember, and you might ask, well, why did you give it that name, you guys, you endocrinologists that named this disease? And so I can tell you, because it does involve the infundibulum, which is that pituitary area, the pituitary stalk that goes from the hypothalamus down the pituitary. It does involve the pituitary, which is a hypophysis. But in actuality, the reason we gave it that name is endocrinologists were always envious of every other endocrine organ that had an autoimmune etiology for dysfunction of that organ, but we didn't. And when we finally found that we had one, we gave it the longest possible name so that you would recognize and remember it, though it's perfectly fine to abbreviate it LIN. This is what it looks like in a patient that I saw in our clinic, this bulbous thickening of the pituitary stalk due to the lymphocytic infiltration. And for those who want an easy way to remember this, just remember this is Hashimoto's of the posterior pituitary gland. The same way that lymphocytic infiltration destroys the thyroid in Hashimoto's thyroiditis, it can destroy the posterior pituitary and lymphocytic infundibular neurohypophysitis. Hashimoto's takes longer to reach the stage of hypothyroidism, whereas this disease can go very quickly in terms of weeks to a month or two to develop diabetes insipidus. Importantly, since most of you know that we are seeing a lot of hypophysitis due to checkpoint inhibitor therapy, CTLA4, PD1, PD-L1, this is not the same as lymphocytic infundibular neurohypophysitis. Matter of fact, there's almost no reported cases of diabetes insipidus or AVP deficiency from checkpoint inhibitor therapy. So these are two different pathophysiologies. Don't make the mistake of lumping them together. So AVP resistance, what we called nephrogenic DI, still do, but we're trying to gradually changes that. What we discovered recently, because I'm trying to bring you up to date with new discoveries in this area, we've always known it was an X-linked recessive. We knew that was because the V2 receptor that AVP binds to in the kidney is on the X chromosome. Therefore, if it's mutated, it's going to follow the pattern of an X-linked recessive and occurs almost exclusively in males, very rarely in females. But we've discovered that you can also have mutations in aquaporin 2, which is the water channel in the kidney that is inserted into the membrane when AVP interacts with the B2 receptor. And now we know that 5 to 7% of these cases are due to aquaporin 2 mutations rather than vasopressin receptor mutations. The clinically important point there, more for pediatricians than for adult physicians, is that while the B2 receptor mutations are X-linked and therefore are almost always in males, the gene for aquaporin 2 is on an autosome, not on an X-linked chromosome, and therefore it can occur in either males or females. So if you see a young female with nephrogenic DI or AVP resistance, it is probably because of an aquaporin mutation, not because of a B2 receptor mutation. This just shows all of the mutations of the B2 receptor that can cause nephrogenic DI. This one at the arginine at 137 is particularly interesting because depending on what that mutation is, you can either have an inactivating mutation of the B2 receptor and therefore nephrogenic diabetes insipidus, or an activating mutation, and that's shown in this box here. These two amino acid mutations of the arginine result in SIDH because it's activating the receptor constitutively, and this one results in DI because it's inactivating the receptor. So a clear hotspot in terms of mutations of the B2 receptor. What have we found out new about diagnosis? Again, I just not summarizing everything about DI, just what I think the new developments are that you all should be aware of in terms of diagnosing this disease. So many of you know that the traditional test for differential diagnosis of polyuria and polydipsia that wasn't due to diabetes mellitus. Obviously, you always rule that out first by measuring urine glucose or just dipsticking the urine for glucose. But once you know it's not diabetes mellitus and you have polyuria, polydipsia, you need to distinguish between all the different forms that I showed you previously: central DI or AVP deficiency, nephrogenic DI or AVP resistance, and the important confounder of primary polydipsia, people who just drink too much. And obviously, if they drink too much, they urinate too much too. The most common cause of polyuria and polydipsia in Western countries is unequivocally primary polydipsia. And we don't want to go treating all those individuals inappropriately with desmopressin, which actually can be very dangerous because of the development of hyponatremia as they retain the water that they drink now in the presence of being treated with desmopressin or DDAVP. So if you look at this cartoon, that's pretty much in most of the textbooks of medicine and endocrinology, it's not too hard to distinguish complete central DI from nephrogenic. So there's no concentration of the urine, but either after a prolonged water deprivation of 10 or more hours, nephrogenic doesn't respond to administration of AVP or DDAVP, whereas complete central DI does, shown in the blue. The big problem with the water deprivation test, other than the fact that people in our field have described this as a form of torture, sort of the opposite of waterboarding. Instead of forcing a patient to drink a lot of water, you're depriving them of water, which is extremely unpleasant as you get out to 10, 12, 14 hours for almost all patients. But the big problem is here in the middle, very poor differential diagnostic value to distinguish a partial central DI or AVP deficiency from primary polydipsia, very substantial overlap. And the test we've always used is that after they've reached a maximal uric concentration, shown here, then if you administer AVP or DDAVP, Partial central DI will still have an increase in the euosm. Primary polydipsia will not. We'll come back to why they don't and what that means in terms of their disease in a second. Now, the biggest advance in the field, and I mean the biggest by far, without any question, is the way in which we measure AVP. Because AVP, if you look at the actual prohormone up at top, it's at the very end, the amino end of the prohormone, and it's only 9 amino acids. 9 amino acid peptide is very difficult to measure via a radioimmunoassay. Those of us who do it for research purposes can do it. Commercial labs, not very accurate at all. But the actual prohormone is larger, 145 amino acids, than the 9 amino acid vasopressin. And we now have assays that are able to measure the C-terminal of this prohormone. It's a glycoprotein, and it's been given the name copeptin because it's secreted along with vasopressin. So, they're both part of the same prohormone, so that when the posterior pituitary shoots out a neurosecretory granule into the blood, it releases both AVP and copeptin in equimolar amounts. And therefore, if you measure copeptin, it's what we call a surrogate measure of vasopressin. And we do that a lot in medicine. So if you have a diabetic patient with the other diabetes mellitus, and you want to try to ascertain whether that's type 1 or type 2 diabetes mellitus, then you will not measure the insulin level, you will measure the C-peptide level, because C-peptide is part of the insulin prohormone. So anytime insulin is secreted, C-peptide is secreted, and it's easier to measure than insulin. Insulin is destroyed more quickly, just like AVP is destroyed more quickly. So think of copeptin to AVP the same way you think of C-peptide to insulin, and you won't forget that that's a good surrogate measure of the ability to secrete AVP. And so if you look at algorithms now we have for diagnosing AVPD or deficiency or resistance, it's shown here. I'm not going to go through it. You can look at the reference if you want more details. But you can do a water deprivation test if you want to torture your patient. That's perfectly fine. It still can be interpreted in about 70 to 80% of cases. But a better test are these tests involving copeptin. If you measure a basal copeptin and it's over 21.4, which is their cutoff, you have a diagnosis of nephrogenic DI or APP resistance. There's no other diagnosis possible. Your workup is ended. You got the diagnosis, that's what they have, and you treat them accordingly. If it's less than 21.4, well, it could be central DI or AVP deficiency, or it could be primary polydipsia. So you need to go further. There are 2 tests that have now been described that will do this. One is to infuse hypertonic saline, and depending on what the copeptin level is stimulated to, with a cutoff of 4.9, you can differentiate with about a 95% accuracy primary polydipsia from either complete or partial central DI. So obviously, when this figure was made in one of our chapters, we hadn't yet changed the terminology to AVPD, so it's still called DI, which is going to persist for some time. It's not always easy or safe to infuse hypertonic saline to get to a sodium of 150, which is the criteria for stopping the test. So the Swiss group has also looked at an alternative stimulation using arginine infusion. And as shown here, patients with primary polydipsia, shown in blue, and the blue line, respond to arginine with an increase in copeptin, and patients with partial or complete central DI do not. So this is becoming more the preferred test to distinguish amongst these different types of polyuria and polydipsia. And I think there will be some other tests coming out as well to make it even simpler. But the point is, we now know enough to know that we don't need to always go through a water deprivation test to make the diagnosis appropriate. And last thing I want to talk about is it shouldn't be surprising because we have so many diseases where there's overlap between different forms and subsets of that disease. And it shouldn't be surprising that that occurs here as well, that there are instances of combined AVP deficiency and AVP resistance, or overlap between those two forms. And I'll show you just one example of that, and I'll show you how that helps explain some observations that we made and know for a long time, decades, but were never really completely understood. So if you look at the urine concentration mechanism in the kidney, so this shows a kidney collecting duct cell. It sits between the urine and the collecting duct, or the nascent urine, the collecting duct, and the blood and the vas recta. The AVP-V2 receptor is on the blood-borne side, and this membrane, we call it the luminal or apical membrane, is generally not very permeable to water. So if urine makes it into the collecting duct from the more proximal area of the nephron, it's not going to be resorbed. It's going to go straight out the kidney, out the ureter, out the bladder, out the body. That's a diuresis. However, if AVP is secreted and activates the V2 receptor, it activates a signal transduction process involving cyclic AMP, but the end result of that is insertion of these aquaporin-2 water channels into the membrane. It's like poking holes into that membrane. It now becomes permeable to water, but they're very specific holes. They don't let everything through. They really are the diameter of a water molecule, and therefore they pretty much only let water through. And water then flows across osmotic gradients into the collecting duct cell and out the backside into the blood. And that's what we've always called antidiuresis. Antidiuresis means urine concentration is the way we conserve water when we need to conserve water. So if that's the process, how is that involved in primary polydipsia and even in some cases of central diabetes insipidus? You know, I'm a translational physician and scientist, means we study things in animal models, cell cultures, the lab, in order to understand the disease process, pathophysiology, and then translate it back into what it means for clinical care of patients. And this was an animal study done at the NIH that shows this. So the Brattleboro rat is a rat that has hereditary diabetes insipidus. There's a mutation of the AVP gene leading to complete DI in this rat. They excrete urine more than 5 times their body weight every day, even more than humans do. So in this study, they looked at a rat type Long Evans that has normal AVP synthesis and secretion compared to these Brattleboro rats named after Brattleboro, Vermont, where that's a different kind of eponym. It's actually not an eponym because it's not a human name. It's just a name of the town where this mutation was discovered. I guess that's okay because it's not an eponym, but I haven't thought about that too much. Anyway, they looked in this case, because in translational science, you can take the kidney out and see what's going on. They looked at the aquaporin-2 water channel content in the kidney, and the Brattleboro rats had a markedly decreased amount of aquaporin-2 in the kidney. And then they treated them with AVP. So this is like you get a patient on the ward, has complete central DI, they're urinating 10 to 15 liters a day, and you put them on DDAVP as an appropriate treatment. You don't see an immediate restoration of normal urine concentration. It takes several days to get there. And this explains why. They treated these rats with an AVP infusion. They measured how long it took for them to recover the kidney aquaporin-2, and it took a minimum of 3 and actually 5 days to get up to a normal concentration. So if you look at this cartoon, you will have inability to concentrate your urine if you don't have an intact V2 receptor or AVP. But also you need a pool of aquaporin-2 water channels in the kidney to respond to the AVP and the AVP receptor signaling, because if you can't insert enough channels into the apical membrane, you will not have a complete maximal antidiuresis. And so that's what happened in these rats, and that's what happens to explain these findings. This is the traditional water deprivation test. And as you look at the test, you should have 2 questions as you just don't look at it, but think about it. So 1, complete central DI. Why? They're lacking desmopressin. They have a hormone deficiency. They're lacking ABPs. They have hormone deficiency. You give them either ABP or desmopressin, and they do concentrate. But how much? The criteria is they only have to increase the urine osmolality by 50%. So that means if they're excreting a urine with an osmolality of 100, if they increase to 150, that's a diagnosis of central DI. But why don't they go all the way to normal? They're lacking AVP, you're giving them AVP. What's keeping them from maximally concentrating their urine? What's keeping them is the decreased aquaporin 2 content in their kidney. They can respond to the AVP to a degree, but they can't concentrate urine maximally if there's not enough water channels to move into the membrane. That's why they will not, on a single dose of AVP or DDAVP, maximally concentrate. You keep on giving them DDAVP daily, and then by days 3, 4, 5, they reach maximum urine concentration. So you can understand this. We've seen this. We know it for a long time. We couldn't really understand it until we understood about aquaporin 2 water channels in the kidney. And so the last point I'll make is here, these patients with primary polydipsia, normal pituitary, normal AVP, normal kidney, normal AVP receptor. Why don't they respond after water deprivation when you give them a dose of AVP or DDAVP? I mean, you would think they should, everything's normal, and you're just giving them AVP, which for them is suppressed because of the water drinking. Why don't they respond? It's the same reason. With chronic polydipsia, what happens is that the increased water intake suppresses the synthesis of aquaporin 2 water channels in the kidney, because that's a cyclic AMP dependent process. If you are not activating the AVP-V2 receptor in the kidney, the collecting duct cells have low cyclic AMPs. That results in decreased synthesis of the aquaporin 2 water channels. So patients with primary polydipsia, in fact, do have a form of diabetes insipidus. It is a nephrogenic type of diabetes insipidus, and it is now better explained by the terminology we want you to use, which is AVP resistance. They have AVP resistance because of the downregulation of the aquaporin water channels. So, you know, we deal a lot of times with people competing in athletic events who want to do better. So you know, we see doping, obviously, but testosterone growth hormone, and we can check for that now, so it decreases the likelihood of that occurring. When instead of people doing endurance events, such as cycling or running, athletes involved in resistance events, i.e. wrestling, boxing, etc., they need to make their weight class, because you obviously do better the lower your weight class. And the traditional way of doing that was to take diuretics right before you weigh in, so you got rid of a lot of water, decreased your body weight. But we can screen for diuretics now, so they can't do that anymore. So I will tell you the preferred way. It's incredible how word of mouth among athletes will increase the uptake of I won't say medical, but of procedures way more than we influence it as physicians influencing what to do. So what they know to do now is for 5 days, they are polydipsic. They will drink about 8 to 10 liters a day for 5 days. And on the day before weigh-in, they stop drinking. And as they stop drinking, they urinate a lot. Why do they urinate a lot? Because they have water diuresis, we call it aphoresis, because their kidney aquaporin 2 levels are suppressed. So they will come in at a lower weight because they've just lost about 3 to 5 liters in terms of water, and it allows them to make their weight more easily. So I'm not telling you this because I recommend it, but I'm telling you this, it shows the power of knowing the pathophysiology of what's happening. They do develop, and they did develop in themselves a form of AVP resistance. And that AVP resistance is due to downregulation of the aquaporin 2 water channels in the kidney. It has a sound physiologic basis. It causes that pathophysiology. And for the benefit of the athletes, is totally non-detectable. There's no way that you can tell. We can't biopsy the kidney to measure aquaporin 2 levels. So this is a completely undetectable way of cheating in terms of making a weight class. So I just offered that as an example of how knowing the pathophysiology of these diseases helps you understand things that are happening today. So my summary, DI name change. We published our proposal in an editorial, multiple international journals. It's been endorsed by all major endocrine societies across 5 continents now. So there's no question this is going forward. It's not just a proposal anymore. So how do you deal with this? How do you all deal with this when you're writing up cases or you're describing cases? We don't recommend a 100% change of terminology because it's too hard. It doesn't happen that quickly. People have to get used to new terminology. The rheumatologist taught us that it took them 10 years to really have good uptake on changing Wegener's granulomatosis to its current name. So what we recommend is you do the examples I'm showing here. If you have a patient with AVP deficiency, that's what you make a diagnosis of. But then in parentheses after it, you put the old term, central diabetes insipidus. The same for AVP resistance and nephrogenic diabetes insipidus. And we think that using this going forward, at least for the next 5 to 10 years until the name change gets more widely adopted, will not create any confusion in people's minds because you do have both of the names for the disease there. You're just giving the preferred one first and the what we call the old one, but still one that's being currently used in parentheses. And we hope that, after 10 years, we'll be able to do away with the parentheses and just call it what the new name is, AVP deficiency, AVP resistance. I can tell you that our patients wholly endorse this concept. They're the ones that we're making the change for. It's for their, not just for their preference, but for their safety. We think it's due time that we got a divorce from diabetes, and that's what we're proposing right now. So thanks for your attention. Again, a little bit of a different grand rounds, but something I think that is instructive in terms of telling you, why we're making this change, why it's important, and why there might be other diseases out there that would benefit from a name change from an eponymous name named after some individual to one that better describes the pathophysiology of the disease itself. And certainly what we proposed in terms of ABP, DNR, that's the pathophysiology, and that's the way it should be named in our opinion, which again is a broad international opinion of experts in this area.